kids and I'll be home soon, if that's them. It's lovely to see you all. My name's Iain Beardsell. I'm a consultant in emergency medicine in Southampton, and I've done a lot with St Emlyn's, and I recently joined the fraternity of the Tech Bros by launching an app, and it's called MedPod Learn. I don't know why I'm saying that now, but if you're a friend of mine and you were part of the sweepstake about when I'd first mention it, the winner is 819. So if you had 819, that's when I first mentioned MedPod Learn. A huge welcome to you all. It's been a long travel to get here. If you've come like me from the UK, you've already made it through Geneva Airport. That's a sort of mission in itself, so well done on doing that. If you came by train and you accidentally perhaps got the ticket that was for one particular train, and then you didn't know it was going to be a bit late, and then you get on the train and the nice guard looks at you and talks at you and says you're on the wrong train, and so you've made it here and you can relax. So what I want you to do for this session is just to relax. The plan of what we're going to do is I'm going to facilitate, I hope, two amazing people chatting about the latest evidence. And we're going to take you through some evidence from pre-hospital emergency medicine and intensive care medicine. The latest papers, I've got two great people to talk about those papers, and then we're going to also try and bring in some of the faculty who you're going to be seeing later in the week. My real aim for you for the end of this session is to take away a few clinical pearls, a few nuggets, but just to feel a part of that TBS vibe, to feel like you can chat to people, and just to feel relaxed and looking forward to the end of the week. So that's my aim by 10 o'clock. Now, the two people that I've got with me, Simon, Carley and Brian Burns, you will have seen before, almost certainly. Oh, thank you. That was good. So they look like this, which is also like that. And they are professors of emergency medicine and pre-hospital care, but they are active clinicians. So they are doing this stuff day in, day out. And I think all too often, that's what you'll hear at this conference. It's people doing the job. Sometimes you buy a ticket and you go and you think, yeah, but when you last see a patient? If you want to know about these two, they've done all sorts in the last year. If you Google Sydney Morning Herald, you'll hear stories of a hero, Brian Burns, out jogging, comes across somebody, and I'm not making this up, who's been attacked by a shark in Australia. He casually just then resuscitates this person who's trying to bleed to death, and then I think finishes his jog, and off he goes. And that's Brian. And then you've got Simon, who's doing, if you read the Harry Potter books, you know Hermione Granger, how she has a time turner thing and she can do things twice. That's how I feel working with Simon. I first met Simon about 10 years ago at a conference, and he's the great example of if you meet people at a conference, good things can come for you. So chat to people. But he's a consultant in emergency medicine, dean of the Royal College of Emergency Medicine, doing pre-hospital care. This year has attended major incidents, not least the Jewish synagogue attack that happened in Manchester. So these are people who are really doing it. So hopefully their expertise will come to you. And how are we going to do this? Well, we're going to introduce a clinical case just to try and ground what the paper's about. Then they're going to do a bit of telling you about the paper, some of the methods, all that critical appraisal stuff that we depend on nerds to do for us. And then we're going to have a conversation, and hopefully we'll bring some other people in to have a chat about it. Now, as part of it, you've already got the Wi-Fi code. The Wi-Fi we thought wasn't going to work very well, but it seems to be better than the one I have at home. So please do log on. And then this QR code should, hopefully, bear in mind my age and that I'm trying to use technology. So be forgiving. That should take you to an online poll. Has that worked? Okay, this is really good news. The QR code will appear on the different slides. Just in case the slightly myopic of you, there you go. I should have put that up at the beginning, shouldn't I? That would have helped. Now, we're going to start by you having a go at a poll. Okay, so some of you ski, I guess. I want you to just have a go at this poll. Let's see if it's working, and then see how we're doing. There should be the sound. There's some sound on that.
You never take advice. Someday you'll pay the price. I know. I've seen it before. It happens all the time. You're closing the door. You leave the world behind. You're digging for gold. You're throwing away a fortune and feelings, but someday you'll pay.
Now, this will tell us a lot, won't it? Okay, so, hello, my brothers. It's nice to see you're here with me. stumbling your way down. I've skied for 2 days. I've come here with all my ligaments that I arrived with intact. That is a victory. There's always these people, aren't they? And in this crowd, they tend to look a bit like Vikings, I've noticed. Blonde hair, flowing, bit of stubble, the kind of guy I wish I was. But that's where we're at. And there will be plenty of this. So remember that this is important. That's part of our socialization. Let's crack on with some evidence and some papers. So we're going to start off with pre-hospital emergency medicine. And we're going to just think a bit about a case. So let's imagine you're on a night hem shift and a 24-year-old has skidded on the snow. Could happen. And is GCS6 with a blown pupil. You do an RSI, it's a snowy roadside, you get the tube in, you're feeling pretty good about yourself, it goes perfectly, paramedics patted you on the back, and you're feeling great. And then you notice that the blood pressure just starts to drift downwards. And you start to wonder, well, does this really matter? If you have a patient with severe traumatic brain injury, what do you most worry about in the first few minutes after that happens? Click a button. Commit to an answer. Be honest. If you're not sure, chat amongst yourselves. It's nice that 45% of you thought that, because that's what we're going to talk about. I mean, we all worry about this, and I've got to be honest, I worry about this bit here. But let's hand over to Brian, who's going to tell us a bit about, does it really matter after traumatic brain injury if we have a little bit of hypotension? Brian, over to you.
All right, good morning, everyone. Right, so this paper is pre-hospital, post-intubation, hypotension, and survival in severe traumatic brain injury. So we know that hypotension in severe brain injury is really bad. It does happen in the pre-hospital arena. We know that. We pretty much accept that pre-hospital RSI is the gold standard for severe brain injury. But what does that do? How do we mitigate it? What's the effect of it? So this was a retrospective review of another study that these 3 HEMS units in the east of England did. And basically, they got together. They were going to review the severe brain injury and look at the effect of hypotension on 30-day mortality. So what they defined hypotension as a systolic less than 90 within 10 minutes of induction of drugs, and they looked at 30-day mortality in severe brain injury. So that was defined as an AIS of greater or equal to 3. This was a post-hoc secondary analysis of another paper, and they all had the same operating procedure and how they performed anesthesia, and that's important to note. So they used ketamine 1 to 2 milligrams per kilo, they used rocuronium 1 milligram per kilo, and they used fentanyl 0 to 3 mics per kilo. Okay, so here are the results. So they reviewed 555 patients. Vast majority are blunt trauma. 75% were male, and you can see they had quite a severe brain injury group, especially with AIS 4 and 5 make up quite a lot of the cases. So in terms of survival, if you had pre-hospital hypotension in this group, your mortality rate was 56%. Your survival rate was 56%. If you had no hypotension whatsoever, your survival was 72%. So huge difference in outcome. Now, if we look at this graph here, what you've got is a plot looking at the adjusted odds ratio of death for the lowest post-intubation systolic pressure. So that's the lowest post-intubation pre-hospital of severe brain injury patients with polytrauma. So these have polytrauma. On the right favors a higher mortality rate. On the left favors survival or lower mortality rate. And you can see there that when you get to about the 100 systolic of 100, the inflection starts to head towards death. And in some ways, that systolic less than 100 is the new 90. As we're aware, a lot of the major trauma protocols or hemorrhage activation or massive transfusion protocols are based around this 90 systolic. And if you take away one thing from what I say today, I think it's that 100 is the new 90. We do know that this is also borne out in studies around hemorrhage, prediction of severe hemorrhage, and prediction of bleeding and exsanguination as well. Now, if we look at adjusted odds ratio for death for the lowest post-intubation systolic for isolated severe brain injury, that effect is exaggerated, or that pressure association is exaggerated way off to the right, favouring mortality once you get below that systolic of 100. And if you look as you go further up, if your systolics get down below 80, 70, you're really high risk of death. So hypotension is bad, but can it always be avoided? Is this association or causation? Now I'm going to give some thoughts around this study, and then I'll ask Simon as to what he thinks. When you look through the paper, it's retrospective, but when you look through it, about 3/4 of the patients did not get what I would call a preload boost prior to RSI. I think as pre-hospital services, we've become very good at predicting when someone's going to drop their pressure or acknowledging that they're severely injured, and usually giving them some preload with blood products before anesthetizing them. I couldn't see anything in the paper in terms of shock dose of drugs, and that's why I kind of talked about the RSI SOP. I'm not sure from the paper whether the drugs were adjusted for shock. I presume they were. And then in terms of fentanyl, in a lot of the SOPs in RSI, they're given, the 3 drugs are given bang, bang, bang. We did a study in Sydney, a small study called the FACT trial, and we looked at the association of blood pressure on fentanyl during RSI. And what we noticed actually, it was about 2 to 4 minutes after the RSI is when the fentanyl had its effect and dropped the pressure. So I'm not sure if the lag effect of fentanyl was taken into consideration. Also, hypotension before induction, those patients were excluded. So in some ways, we may be overestimating the effect of RSI and hypotension pre-hospital. And this study was run prior to the increased use of invasive blood pressure monitoring. We're using a lot more invasive blood pressure monitoring, which gives us beat by beat or second by second information rather than cycling every 2 minutes. Simon.
Just to follow up on a couple of those things and to build on the work that you did with the FACT trial, there's a couple of things here. With the blood pressure, if you think about how and we'll talk about it in some of the other papers later, what does hypotension mean for this group of patients? Is it a single reading? So is it they've got a normal blood pressure for a period of time and they suddenly drop down for 30 seconds, then come back? That's clearly a very different group of patient to a patient who may be dropping down, perhaps not as deep, but for a longer period of time. So the dose of hypotension, if you think about hypotension as a dose, it's how bad it is and how long it goes on for. We've not really looked at that in this paper, although they have alluded to that they want to look at that in the future. It's certainly something we're doing in the Northwest as well. And the other is about the fentanyl. I mean, this paper and your paper have changed my practice and changed several people in my cohort of clinicians, is that for these patients, we'll really, really, really try hard to get an outline in as soon as possible. And then what we'll do is we'll give them a very small dose of fentanyl. And if nothing happens to the blood pressure, they're going to get a bit more fentanyl. And if nothing happens, they're going to get a bit more fentanyl. But if that first small dose drops the BP, we're out. We're not giving any more. So we're tailoring these two papers together to try and mitigate this. Does it make a difference? Don't know. Haven't seen that data yet. But that's where I think we're heading with this. It's more nuanced. It's more neurocritical care. And there is a pressure of time to get these patients off to sleep. But actually, they're not bleeding to death, the isolated heads. Maybe we just need to slow down a little bit and just do it really, really well. That's my feeling. That's what I think this is what's telling us.
And just on that, one of my colleagues in Sydney, Chris Partica, is running a study at the moment to look at shock in trauma and hemorrhagic shock mimics. And these isolated severe brain injuries do behave like hemorrhagic shock and are quite hard to differentiate from polytrauma bleeding plus head or just head on their own, because they often have the same mechanism. So that's another kind of key area of interest and focus.
James is in the room somewhere, I think. I mean, he should be. He's speaking in the next session. There he is. And James was the first author of this paper. I didn't tell him we were talking about it. But James, I thought you could give us half an hour. No, I kid. But James is here. This is the caliber of the speakers you've got coming up later in the week, people who are writing these papers. And if you want to ask James some more questions about it, I'm sure he wouldn't mind at all. And he's there in glorious Technicolor, which is rather nice. OK, let's go on to paper 2. And case I want you to imagine for this is an urban stabbing happening all too more commonly and sadly in our world. You're 10 minutes from a major trauma centre, and you get to a 19-year-old who's shocked with a single left-sided chest wound. He's losing his output just as you start getting to go, and you start some CPR. You got a thoracotomy kit in your bag. The hospital's just 10 minutes away, and you think you might be able to get there with a bit of gas, and you know there'll probably be a trauma team standing by. He's in cardiac arrest, he's been stabbed. Do you stop the ambulance and start doing a thoracotomy, or do you press on the accelerator and get to hospital? Brian.
All right, so this paper is called Improved Decision-Making for Pre-Hospital Resuscitative Thoracotomy and Traumatic Cardiac Arrest, a Data-Driven Approach. And this is from the London HEMS, or London Air Ambulance Group, and this is a fantastic paper. You'll note we've picked out some retrospective papers and also some randomized controlled trials, but this is truly filling the void of information in terms of traumatic cardiac arrest. So this was a retrospective review of over 600 thoracotomies, prospectively collected. So in London Air Ambulance, they prospectively collect this information. And what they did was they did a data-driven approach to look at these cases, analyze them, and then come up with a practice change or try and inform a pragmatic approach in terms of how we manage traumatic cardiac arrest. Now, what they tried to do in this paper, which is fantastic, and unfortunately this does not exist in a lot of systems, but they tried to look at the association between the injury location and the cause of traumatic cardiac arrest. And so what they did was they essentially matched the wounds in 9 areas on the torso and compare them to the pathophysiological cause that was found either in the operating theatre or in the coroner's report. So matching anatomical areas and actual findings. And then they looked across these areas and looked to see was there tamponade, exsanguination, or both. And what they found was that essentially if you look at these little drawings here, or these diagrams, what you see is in these various different zones up towards the neck, it's essentially exsanguination. A bit lower down, mainly exsanguination, tiny bit of tamponade. It's only when you get down into the cardiac box or right anterior in the torso, you head towards tamponade territory. Similarly, on the right and left lateral, very unlikely to be tamponade. Usually exsanguination, can be both though, so you could be stabbed through the side and get to your heart as well. And then epigastrium in red there, tamponade more likely. Stab in the back, usually exsanguination, both about 13%, and then stabbed lower down, tamponade is 0. And what all that looks like is this. And this is a beautiful diagram. It's actually one that I've kind of etched into my mind in terms of when I go and see a patient, and we'll talk about that. So you can see in the light yellow, less than 1% chance of having a tamponade. So stabbed down here, stabbed up in the neck, very unlikely. Stabbed in the side, 1 to 5% chance of isolated tamponade. And that's important because we'll talk about the order of interventions that you do at the scene. And usually that's a 2-person, doctor paramedic team, or sometimes you could be lucky enough of a 3-person team. But once you get up into this cardiac box area and epigastrium, it's over a 30% chance of having a tamponade. Now, what they found was that stab wounds were predictive of the injury. In other words, if you were stabbed here, you're likely to have a cardiac tamponade, or more likely. Whereas ballistic injuries were not predictive as to location, and usually exsanguination was the cause of death. Now, interestingly, in their blunt trauma cohort, usually it's exsanguination, but 5% of them had a tamponade. All right. Now, these diagrams I think are fantastic, because what they've done here is they've done a forest plot, and they've looked at the tamponade cases, which were 69, the exsanguination cases, which were 273, and they're looking at the presenting rhythm to the team and looked at the duration of traumatic cardiac arrest. So just if you kind of bear that in mind and look at tamponade on the left. So you look at duration of arrest as to when you see them or as they present to you. And you can see very early on in tamponade, it's sinus rhythm, then becomes sinus bradycardia, then becomes agonal, and by about the 15-minute mark, it becomes asystole. And then if you look at right in terms of exsanguination, similar, tends to come down a bit steeper, but once you get to about the 12, 13-minute mark, they have become asystolic. Now, what does this mean? Well, if we look at survival now with respect to those rhythms, that cardiac electrical activity, you look at survival in the vertical and then the rhythm on the horizontal. Now, if you look at tamponade first on the left, you can see if you get to a tamponade and they are a patient who meets the kind of criteria for tamponade, so stabbed in that area, and they have a sinus rhythm or a sinus beat, and you do a thoracotomy in their system, it's a 60% chance of survival. When you get to sinus bradycardia, you can see it drops. Now, red is unfavorable neurological outcome, and gray is good outcome. So as you get further on into sinus bradycardia, then to agonal rhythm, the penalty is a survivor that's more likely to have an unfavorable neurological outcome. And when you get to asystole in tamponade, you might get some survivors that are neurologically intact, but not many. With exsanguination, it's a different story. Literally, you can see far less survival. You go from sinus rhythm, sinus bradycardia even, you're getting into potential unfavorable neurological survival. And then when you get to agonal rhythm and to asystole, there are no survivors. So what they've done is they've pragmatically made this framework to try and combine the injury location with the suspicion of the underlying pathology, tamponade versus exsanguination, and the presenting rhythm, and the known timelines from their cohort to try and predict what we should do. So if you look at the suspected underlying pathology of the traumatic arrest, if it's tamponade, the presenting rhythm is an organized rhythm, they need a thoracotomy. If presenting suspected underlying pathology is exsanguination, basically, and they've got an organized rhythm, it's damage control pre-hospital care, which is large bore access, blood transfusion en route, and get them to a trauma center. If they're agonal or asystole, and they've tamponade, but it's less or equal to that 15-minute mark we showed you, then it's a resuscitative thoracotomy. But if it's agonal or asystole and exsanguination, the thoracotomy is not indicated pre-hospital. So are these evidence-based decisions? Arguably, I think, as good as it gets. A lot of the big trauma guidelines, the East and the West trauma guidelines, ILCOR, they're not based on high-quality evidence in terms of thoracotomy. And this cohort is one of the biggest out there. The question is, is it generalizable? We know London HEMS is an extremely high-performing organization. And when you see resuscitative thoracotomy, that means from the skin to incising the pericardium and sorting out, relieving the tamponade should be under 2 minutes. And you have to ask yourself in your system, can you do a thoracotomy in under 2 minutes? And the decision-making is quite complex. I know, Simon, you've got a couple of thoughts just around that decision-making and, when would you do it? And
yeah, so if you put all of those things together, Bryn's clearly shown that time is a real determinant of outcome with this group of patients. So you have to act quickly, and that's your decision-making has to be very quick, and your procedure needs to be quick. So you can train for the procedure, that's okay. Decision-making, at the moment, most of the services that work at, the decision-making is very, very simple because it's very, very crude. Did this patient have signs of life within the last 10 minutes? Do a thoracotomy. This is making that much more, putting more finesse on it, making it more detailed, making it more evidence-based. But then you're judging, can I remember what that table was? Where is the injury? What were the percentages in each of those different areas? And what's the timing and what's the rhythm on the screen? Putting all of those things together. Now, I think you can do that, but you do have to train quite hard for it. You have to cognitively exercise your mind about how you would do that through a bunch of scenarios. If you're doing this on a regular basis, I think that's achievable. For some people in, say, my trauma units, the hospitals in the UK who don't see a lot of major trauma, this might be a step too far in terms of complexity. I might probably keep them on a simpler one. That sounds a bit patronizing, but it might be that we need to exercise that. The other one in here is, of course, is the exsanguination thing, is how do you resuscitate somebody from exsanguination? Because we do need to still maintain some degree of coronary perfusion pressure. Mm-hmm. And thoracotomy may be a route to doing that by causing, external aortic compression, or RIBOA if you can do it, or something like that. So there's other things that I think this working group, because this is the exsanguination working group, I think we're going to hear more from this in future years. I'm really looking forward to see how that pans out.
There's two other elements. In terms of thoracotomy versus ongoing blood product resuscitation, ultrasound was mentioned in the paper, and there's a couple of challenges around ultrasound. One is ultrasound sometimes fails pre-hospital, as we all know. the sunlight, the cold, and really trying to hang your diagnosis on the ultrasound can be quite hard. It takes a couple of minutes to turn on. And as you know, that's a killer when you're, no pun intended, but that's a killer when you're trying to resuscitate someone, you're waiting for this thing to turn on. So in some ways we need systems whereby these machines are on, or they have a better battery life, or they go into a better sleep mode or standby mode. We can get them on quickly and help differentiate those patients. Because in some ways, you know, if you walk up to someone who's been stabbed and you're there, literally if you just have it on, you could go tamp it out, yes, no. The exsanguination thing, I would agree, is a big thing, and this relies on a system that gets teams to the patients extremely quickly. And that's crucial. I know in London, they're pretty good at identifying cases super early on and getting teams to them. But for me, a big take-home, I think, is that anatomical location of the likely pathology. And then also now it's much clearer in my mind when I see asystole on the monitor in exsanguination, they're not going to survive.
Great. So this is the point in time where we're going to just come and chat to our first faculty member. I've clicked through.
Sorry, that was me, was it?
It's all right. There we are. There she is, Claire Park. Now, I've commandeered Hutch, who you'll meet during this week. Hutch is part of the ATAC team. He's young and fit and agile, so I thought he could run around the room. And he's going to do some finding of people for me. I'm going to ask Claire. Claire is a consultant with London HEMS. I was lucky enough to meet Claire at the Tactical Trauma Conference last year, which happens in Sweden. Quick plug for them. If you like this sort of thing, and you also like hanging out with Tier 1 operators, which it turns out my partner really enjoyed doing, the conference is in November in Sweden. Claire, you're part of this service who did this data. How do you think this is affecting your day-to-day practice on the ground in London?
So I don't think I completely agree with Simon, actually, that I don't think it's as easy as it might look on a table. I guess I'm quite lucky that I've got 16 years experience of looking after these patients. So a lot of the decision making for me is probably gut feeling on, is this patient bleeding, or do I think they're more likely to presenting as a tamponade? Certainly that box helps direct the immediate thoracotomy, I think, and we shouldn't be scared of getting straight into the heart because time is really key here. And if it is a tamponade, the survival is more likely. But I worry about the exsanguination patients. Basically, time is the problem in all of these patients, and actually what we really want to be doing is doing all of this before they arrest, whether it's tamponade or exsanguination. We should be getting into that chest as they've still got a heartbeat, because if it's stopped, it's too late. So for the exsanguination, I worry that people are going to go for the damage control pre-hospital care, which is okay if they're not in arrest or peri-arrest, so you can't feel a pulse. But if you start just filling when actually they've lost an output, you're probably not going to manage to get that output back. So I think I think it makes it difficult for our fellows. I think it makes it difficult for people who are trying to do this without the experience. And this guides us, but I think I wouldn't undermine the complex decision making. And I think we still have to think a lot more about that decision making, about whether we just fill or whether we do more on scene.
Brilliant. Thank you, Claire. So putting it all in context. Great. We're going to go on to paper number 3. And this is a chance for you to grab your phones again, because I'd like to hear your opinions. And for those of you who are playing TBS bingo, this is the point at which you can tick off ECPR or ECMO. So that has already happened. I don't even think it's not even 9 o'clock. There you go. That's proper TBS, isn't it? So, quick question for you. How often do you see a patient where you think to yourself, I'd really like to do pre-hospital ECPR?
If I had $1 million, if I had $1 million, well, I'd buy you a house. I would buy you a house. And if I had $1 million, if I had $1 million, buy you furniture for your house, maybe a nice Chesterfield or an ottoman. And if I had $1 million, if I had $1 million.
Okay, so not every day, but a not infrequent occurrence. Let's just think about a case. It's early in the morning and your dispatch calls. You've seen a witnessed VF cardiac arrest. Let's say it's a 50-year-old man. I've got a bit of an obsession with the healthcare of 50-year-old men at the moment. After April the 21st, it will be 51-year-old men. But for now, It's 50-year-olds. There's ongoing CPR. They've got no major comorbidities apart from a slightly dicky knee. And when you arrive, there's high-quality ALS been going for 20 minutes and they're still in refractory VF. Your service has a pre-hospital ECMO capability, but it's really resource-heavy and only available on certain shifts. And you wonder to yourself, is this something we should be doing more often? Is this something that's feasible that we should be offering in our service? Time for Simon's first paper.
Yeah, so you may notice the second author on here. If he takes out a weapon behind my back, then please let me know. But this is the PRECARE study in Australia, which was looking at ECPR in the pre-hospital environment. And there's been a few papers around this sort of thing of late, hasn't there? So there was the sub-5, sub-30 paper from London. There was the New England Journal paper from the Netherlands that came out. There's the ARREST study in the past. We've had a number of different studies around the world looking at the feasibility of this, because we're all terribly enthusiastic. Just for the record, as I said before here, in Manchester, where I come from, we're ECNO, not ECMO, so we don't have it at all. But it is coming, and there's lots of enthusiasm for it. So what did they do? Well, it is Sydney, which is, as you know, a wonderful place, lots of money, lots of people, lots of highly skilled people, and a real interest in advancing healthcare and emergency medicine. So what they did is they set up a service to do VA ECMO at the scene of the patients in out-of-hospital cardiac arrest, and it was set up really as a prospective feasibility study. So we're not really looking for definitive data in here. We're actually looking about whether or not it can be done and how it functions in practice. And I think that's probably fair. And one of the criticisms of the Netherlands study was that they perhaps tried to do a full evaluation as an RCT at a point where they were still developing their service. And the experience from London and from other centres which I've spoken to is it takes quite a while to get reasonably good at this sort of thing. So you need to establish a service. Can you do it? Is it feasible? Does it work in principle? And then perhaps test it a bit later. And I think that's where we are. So what they did is they had set up some teams. They trained a cohort of their pre-hospital people from Sydney Hems. They had the team of 2 doctors who were responsible for the cannulation, getting the person on the pump, and then 1 dedicated critical care paramedic who actually operated the pumps. And the pumps now are pretty small. They're pretty portable. You can get them out and about. And they also had, which I think is really important, is the bane of our life in all pre-hospital care, is they had a dedicated paramedic on dispatch just looking out for cases that they could go to. There's quite a lot of resource involved in this. So there's all the kit, there's the people, there's the training. There was a very, very significant, quite long-winded and really tough training program for the doctors and the paramedics before they would then be allowed to sort of work on the service. So pretty good. What do they do? Well, they try to find this sort of patient. It's actually quite a broad age range. 18 to 70 is a lot older than some of the other studies that have been done. When we did trial this in the northwest of England pre-hospitally, we cut out 55, so you're getting pretty close, and I'm past it. So they wouldn't even come to me if I'd witnessed cardiac arrest, VF, or PEA with signs of life, and at least 15 minutes of conventional ALS before they went for it. And the idea that they could get them on the pump within 45 minutes. And a bunch of exclusions, which I think are perfectly reasonable ones. So they didn't take the asystolics. They didn't take the complex ones. I think that's absolutely okay to do that. So this is a group of patients who, standard methods, we know by the time you've been sort of 15 minutes of conventional resuscitation, if you're still in VF and you're still not succeeding, things aren't going well, you're probably going to die. So it's a group of patients who are probably going to die anyway. Although we've not tested it, it's not a comparative study, so maybe they would have survived. Who knows? What they actually managed to achieve, and again, this is the resource elements that sort of exist around this. They managed to put a team out for about 2 to 3 days a month over a 6-month period. So all that training, all that equipment, all that resource, but actually they were only getting to 1 case every 8 shifts that they were on. So you start with this enormous number of people who have cardiac arrest, or potential cardiac arrest actually is what you're looking at, isn't it, in ambulance control. Could this be a cardiac arrest which is suitable for ECMO? Is it a cardiac arrest? Is it a cardiac arrest which might be suitable for this group of people? Can we get to them on time? Can we get them on pump? Can we actually achieve it? Do they survive? So there's quite a lot of cutouts as you go down. We see this in lots of other papers around ECPR and advanced techniques. So 298 dispatches in that time, 123 of those were in cardiac arrest when they got there, it was potentially suitable, and 12 of them got onto pump. 3 patients survived with a cerebral performance score of 1 or 2, so that's pretty good. So basically pretty much returning to normal life. So, what has this study shown us? It shows us you can do it. It's shown us that you can put resource into this and you can get some positive outcomes from your trial. The question is it worth it? So we can fix it, but we don't really know what fixed means in this context. So Brian, you did the trial, so you were involved in it from the beginning. You talked about it last year at TBS. What are your thoughts on where we are standing now? Particularly around the health economics thing, because I know there's new evidence about that you might want to talk about.
Like I said, last year when I mentioned, this trial, one of the things that I think was important to iterate, that there was a lot of background work went into the case for this. So we looked at the cardiac arrest registry, we looked at potentially eligible patients, we looked at where they are in Sydney, we looked at traffic modelling, which was fantastic with the traffic modelling engineer, and then we placed a rapid response car in the most likely location to get to the most people. And that location is, interestingly, at Sydney Olympic Stadium, and it reaches about 3.8 million people under 45 minutes. Versus the ECMO centres, so the 5 hospitals have access to about 800,000 of the population. So we felt that we had a business case to go and do it. Our estimation of the ECPR eligible cases was probably overestimated. We've just done health economics analysis on this, and in terms of the willingness to pay thresholds, we don't have those formally in Australia. I know they exist in the EU and the UK, but it is commensurate with those thresholds, particularly when you add in organ donation as a spin-off benefit to ECPR. But in terms of what the team are doing, if the team are doing other high acuity cases, other cardiac arrests, if they're doing other shocked patients, then the cost benefit really improves. And the cost per patient is not that significant in terms of the pre-hospital team. In terms of the hospital treatment, these cases are usually quite binary. They declare themselves usually pretty quickly, and they usually are CPC 1 or 2. And in fact, we've had more cases now, and the CPC 2 generally becomes CPC 1. And those who don't survive declare themselves pretty quickly. So I think in terms of teams, it all comes down to the need. You have to kind of look at the need in your own jurisdiction. You have to look at the potential, like the case for it. And then you have to look at the training and then the scalability. Equity of access is a big thing. And this is starting to get out there within Sydney, and then other parts of the state will be wondering what they're doing. We're doing a national study at the moment to look at potential eligibility of ECPR cases around capital cities. So that's where that is up to. Another just slight spin-off is, because we've been going to a lot of cardiac arrests and we're doing a lot of intra-arrest arterial line and transesophageal echo, we're starting to now study other elements of cardiac arrest in non-ECPR eligible patients. And that is particularly with respect to individualized resuscitation and CPR effectiveness. In a small cohort of retrospective cohort, we found that about 25-30% of patients standard chest compression position is actually blocking the LVOT. So we are now going to try and find some surrogate validation of various markers to determine whether the CPR is effective. So we're kind of gone down this other rabbit hole.
No, I think it's absolutely fair. And the other, just reiterate, is the issue of transplantation. So when you start putting health economics questions into this, I think in the UK, the estimate is every kidney transplant that you facilitate saves £250,000. So the service, if we can generate more organ donation through this, and I know they do this in Spain, I know there's ideas of doing this in East Anglia in the UK, and we're thinking about doing it in the northwest of England, is to put people who maybe post-cardiac arrest, they've died, they go back onto ECPR to maintain organ perfusion, they then become donors. Actually, the health economic argument then becomes very much in favour of ECPR programs. And that might be a way that we sort of start seeing these things come into practice from a health economics. Because, your choice of music at the beginning is, these are expensive, but what value do they offer? There's quite a few ways we can look at what that value actually is. So come back in 5 years, I think we're seeing a lot more of that.
Also, you won't get a house in Sydney for $1 million, by the way. So.
Not very nice.
Great.
Yeah,
on to our next paper. Now, I should probably just point out, before we do the clinical case for the next one, that this was very much a group decision about which papers we were going to choose, and the fact that we've picked 2 papers in a row that are authored by Brian is purely by chance. It reminds me a little bit of the episode of Desert Island Discs, where the opera singer went on and chose 7 of her own performances to be played on the radio. It's not quite like that, I promise you. Brian only gave me a few pounds to make sure his papers were in. Let's come on to another case. So let's imagine again that very important cohort of patients, 50-year-old men. They really struggle in this health system. You're on an EMS team where you're called to the scene of a 50-year-old man who's had a cardiac arrest in his kitchen, witnessed by his partner. There are 3 shocks in, still in VF, and you've got 2 choices. Do you stay and try and optimise your ALS, or do you get that patient into the back of the ambulance and into the hospital as fast as possible? Which one should you be doing? Simon, back to you.
Yeah, so this is another study from Australia looking at a different model for trying to advance cardiac care. So just as an aside, actually, the management of cardiac arrest has been relatively static. I know we've just had the new ILCOR guidelines that come out that have made some small changes around the edges, and we're putting the drugs in slightly different times and different temperatures and all that kind of stuff. But actually, it's been relatively static for a long period of time, where what happens is a crew will arrive or they'll be in hospital and they just go round and round an algorithm hoping that something is going to happen and the patient will recover and they get better. And that's okay. It's a level of training. It's a level of skill. But I think at the moment there is quite a lot of momentum in the idea that we need to take a much more individualized approach to cardiac arrest, and we can do much better than just going around the algorithm. Optimizing everything that we can do and looking at other aspects. We talked last year about monitoring things like arterial lines, intra-arrest arterial lines, which we do a lot of, to look at pressures, to determine whether or not what we're doing in practice actually makes a difference to our patients. So I think we are on a philosophical stepping point where we're just going to go from round and round in circles to actually doing something and measuring the output and the effect of what we do. It's relevant to this study because this goes to a question at the heart of many pre-hospital debates that have gone over the years. So this is taking patients who are in cardiac arrest, they've had 15 minutes of cardiac arrest at the scene. Do you stay and just carry on doing what you do there, or do you scoop that patient up, take them to the hospital, and do something else? And what I've said for a long period of time, before maybe 5 years ago, is not a lot of point coming to the hospital because we're just going to do the same thing, which is go round and round in circles. So this idea of scoop and run and stay play, this is the one that you've heard so many times. And the point is, it's a stupid argument because if you're going to transport, if you're going to move in this type of situation with these type of patients, by all means move if it's got purpose. So if you're going to move the patients to do something differently, knock yourself out. If you're just going to move them to do the same sort of thing, it is pointless, isn't it? I mean, you can do it better, maybe, but maybe not. So in this study, what they did is they took these group of patients, randomized to them, multicenter RCT, and decided that the move was to take them to where we could do something different, to a cardiac arrest centre where the options for some patients would be ECPR or early PCI and even PCI in arrest. So Sydney, Australia, prospective multicenter RCT. The patients had to have witnessed a shockable or PEA arrest and have had 3 rounds of ALS or 15 minutes. So it's taken out that group of patients, the ones that we really like, who you shock them a couple of times, they wake up, say, thank you very much, my chest hurts, can I go home? But it's the group of patients who we're interested in, where we might be able to offer additional value. So a couple of things I wanted to know is, could it be done? So can you get these patients from the scene to the hospital and get things done when you get there? And also what the survival was. And again, looking for cerebral performance scores of 1 to 2 afterwards. What did they do? Found 197 patients to work with, average age of 57, pretty close to you, mostly male as we would expect. So yeah, and they looked at these things. So alive at hospital discharge, that's the major output for us. If they were transported, 15% were alive at hospital discharge, and if they stayed at scene, then it was 16%. Now, I'm not sure how many of you are statisticians, but I can tell you now, there's no statistical difference in these results. I didn't put the P numbers on, I didn't think it was necessary. So there is no difference, but an overall survival was 19% in both groups, if you took out the other bits and pieces. So of the groups that came through, there's no big difference. However, I quite like the concept of moving patients with purpose. If you're going to do this, if you don't have the opportunity to do pre-hospital ECMO or pre-hospital services we just described in the previous paper. And the problem with this, it's a good idea, but it didn't deliver what we thought it was, or didn't deliver what the authors thought it would. And we saw very similar in the trial that was done in London which again, I think we presented at TBS last year, where there was a move to cardiac arrest centres for VFVT patients. Again, that showed no difference. And one of the issues was that in this trial, it again comes down to some aspect of the systems. It probably wasn't underpowered. 197 patients isn't a lot. It was powered for a very big difference in outcomes, probably overwhelmingly was never going to get there in terms of what their power calculation was. There were quite a few delays getting the patients when they arrived into hospital, getting them onto ECMO. I think the average time, if they did get onto ECMO, was 80 minutes from their arrest, which we know from lots of other studies is far too long to get in there. And the availability, again, in the hospitals, it was only Monday to Friday, 9 to 5 or something like that. There's lots of times when you'd take the patient to an ECMO centre, but the facility was just not there to be delivered to the patient. And is it generalisable to other centres? Brian's already talked about the geography, and geography is really important with these patients. About where can you get them to? What are the distances? What are the flows like? What time of day are you? How are you going to get there? How are you going to get your team to the scene? How are you going to get the patient back to the hospital? Having said that, it is in keeping with quite a lot of other studies. Again, we looked at this in the Northwest, and we found that if you're trying to get this group of patients within a 45-minute window to a hospital, even within a metropolitan area, the challenges are significant. So can it be done? Yes. In this circumstance, it could be done, but it's very difficult. And maybe this isn't the model, which is perhaps why they've shifted more to the ECPR at scene type approach. So, Brian.
Yep, I agree with all of that. So I think like a lot of trials are going to, in bleeding, resuscitation, often the pre-specified power calculation is incorrect. And we did have to repower the study. During the trial, it was a very challenging trial to run. It involved about 1,500 paramedics and 13 hospitals. A lot of work in doing it, like a lot of RCTs. But it was the first RCT in formalising an expedite to hospital versus a stay on the scene type approach. I think what it does for paramedics, it says is whether you stay on the scene or expedite, you're going to have the same outcome. Now, one of the things that we did was a pragmatic trial around 24/7. But Sydney, like a lot of places, does not offer 24/7 ECMO, for example. But we had to be pragmatic. We also had COVID during the trial, but we persisted. One of the key things we're doing now is we're now going back to the hospitals as a system and saying, okay, we do have some patients that may benefit from ECMO CPR in our cohort, in our pre-hospital cohort. What do you offer? So we're trying to get clarity from the tertiary hospitals in Sydney that do ECMO and say, okay, what can you offer? Because we do need to give some kind of advice or guidance to paramedics as to what to do. Because it is when you work hard and you get them to the hospital and then they are too late to go on ECMO or ECMO is not available, then, as Simon says, what's the point?
Great. I'd like to introduce another member of our faculty. Hutch, are you ready? Speedy legs on. And we're going to just chat to Darren. Darren Broad is here somewhere. You and your clicky fingers, you two. And I met Darren yesterday on the mountain, and he's a great example of how the fact that this is a global faculty. He's here from New Mexico. He looks like this. His voice will come from back there somewhere. And he is an expert in the management of cardiac arrest. And we were at a bar lunch place yesterday having lunch, and his mobile phone went off with a cardiac arrest alert from Albuquerque. He didn't go, which I thought was a little bit... come on, show some commitment. But Darren, the thing I wanted to ask you, by the way, all of the speakers, I'm not telling you what they all do. You can read about it on the excellent website, and there's very long biographies of how amazing they all are. But Darren, for me, cardiac arrest, VF particularly, the shoot to the moon thing is nobody should die in the next 10 years from a VF cardiac arrest, is what I'm going to say. I think we should be able to stop people dying. What, if you could choose, Darren, would be the one single thing that we should do better that will help people survive VF cardiac arrest?
Thank you for that. I think and this ties into a lot of these discussions, but I think we need to move past CPR. Just as we've gotten good at CPR, we've gotten good at all these algorithms and ACLS, and I appreciate what Simon said about personalizing resuscitation. And I'm all about ultra-early cardiac arrest prognostication, but I figured out that that's really just another way of looking at metrics to show if we're doing good CPR or not in an individual patient. And so I think what I'm most interested in is figuring out how we can personalize CPR for an individual patient. both the chest compressions, but it might also be extracorporeal. But we have to individualize that. We have to look at metrics that would shape that, monitor that, and we're going to find out that this 60-minute window for ECMO is going to change per patient. Some patients have no window. Some patients may have a 90-minute window. But if I could change one thing, I would bring better monitoring of the CPR physiology to the patient.
Fabulous. Thank you so much. And there's other experts in the room. I know Sheldon's in the room. Sheldon Checkers, who's the godfather. There he is. Yeah. And sadly, you're not going to get the chance. But anyway, Sheldon is here. He's the godfather of dual sequence defibrillation. We'll be talking about that later in the week. But just to excite you a little bit about the people who we've got and who you're going to be hearing from. But thank you, Darren, for that. So let's go on to our fifth and final case of our pre-hospital series. And I want you to picture this one. You're on a call with HEMS and you go to a motorway and it's been an RTC and there's a middle-aged driver, approximately 50 years old, who's trapped, pale, clammy, hypotensive, suspected pelvic and abdominal injuries. You're trying to get some IV access. It's time to grab your phones because I want to hear your opinions. You think that he's bleeding to death. You can't get peripheral access. What do you do next? So, what would be your option? IO and accept the flow limit, or would you think about a trauma line? And that's what we're going to think about now. So in pre-hospital trauma, should we be using trauma lines? And we'll explain a bit what those are for hemorrhagic shock. Brian.
All right, thanks. This is another paper from London. And again, I think reporting what you do is so important, and there isn't enough of these papers that have come out describing that. And I love the name of the working group, the exsanguination working group. But that just tells of high performance culture and of people who are trying to drill down to this particular patient cohort. And there's lots of little nuggets in this paper. So this again from London Air Ambulance is a retrospective cohort, and they basically want to evaluate the use and safety of a 14 French trauma line that they use, and that's a MAC line. It's a 14 French with a 9 French distal lumen, and they wanted to look at the primary measure was success, as in can you get it in the right spot, and the secondary outcome measures were efficacy, as in can I get transfusion through the line, by putting a line, is that associated with ROSC, what's the survival to ED, what's the survival to discharge, and they also looked at safety, such as adverse events and complications. The line is familiar to a lot of you. There's various different lines. I know Simon will have a comment on the types of trauma lines that people use. So results-wise, they attempted the trauma line between January 2019 and 2023. They attended 8,104 patients, and 346 had a trauma line attempt. So that's 4% of the total patient population that London HEMS attended. Complication rate of about 4%. 90% of those complications related to subclavian. But you can see, in terms of the success, they managed to achieve the trauma line insertion in 80% of the patients. So they got it in. In terms of transfusion, they got 4 units of blood into the patients with trauma lines versus 2 units without. Survival to ED was 54% in the trauma line group versus 36% in the non-trauma line group, which is an odds ratio of 2.1. And then survival to discharge kind of narrowed down. So it was 30% in the trauma line group and 26% in the non-trauma line group, which was not significant difference. Now, one of the things I wanted to bring your attention to is you look at the cohort of trauma patients. And I think a lot of the trauma patients we talk about at Big Sick are that ISS kind of 25 to 30. So not catastrophic, other end of the spectrum, won't survive, and they're not minorly injured. These are the kind of sweet spot of patients, and the ISS in this group was 26, 27, which is the group you want to go to. They are a very sick population, so 56% of them in both groups or 54 in the successful line and 64 in the unsuccessful, were actually in traumatic cardiac arrest on arrival of the HIMSS team. Of those that did get their blood pressure, that did have a blood pressure measured who weren't in arrest, 60% of them had systolic less than 90. So a very shocked trauma population. Interestingly, it was interesting to see that poll. So London HEMS will usually arrive after the first responding paramedics. So in this cohort, about a half of them had no IO or no IV access before they arrived. So, you can see the rationale behind putting a trauma line in, and overwhelming penetrating trauma. So it's, penetrating trauma is 50%. So it's still very high compared to the rest of us. Okay, these are the access points. So you can see most of them are up in the subclavian, but there are other various different big vessels chosen. Usually ultrasound on all the other vessels except subclavian, which is a landmark technique. This is an alluvial chart of the attempted line. Just if you draw your eyes to traumatic arrest upon team arrival, no, up to the black line, yes. And then you can see as it gets to traumatic cardiac arrest during management, no, yes. So quite a lot of arrested patients, but then you come to survival at hospital admission, it kind of evens up. So there is an effect of putting the trauma line or their treatment that means more of these patients are arriving alive to hospital. And we talked about this last year at the Big Sick. What is the primary function of the pre-hospital teams that are resuscitating? You could argue its primary function is to get the patients to the hospital alive, which they achieved in this. In terms of thoughts, the trauma line is part of a bundle of care of expertise that comes with this team and with this response. So it's hard to single this out as a single intervention. We do know they got more products, and possibly getting more products in will do better for the patient or more likely to get them from arrest to ROSC. There is a resuscitation time bias, though, in any interventions that we do, be it ECMO or trauma lines, because often the longer that people are persisting or the longer they are arrested before they're afforded the intervention, the worse they're potentially going to do. And what would be really interesting is to see the effect of something like a trauma line, for example, or the team much earlier on in the piece in patients who aren't as shocked as you saw there. So less sick. There's about 20% failure rate. It's not clear in the paper why. It'd be interesting to hear if we talk to Claire, who works in the system later on, as to why that is. Were they done en route? Were they done on the scene? Were they done on the ground? Were they done in the ambulance? Were they done in a helicopter moving? It'd be good to know those kinds of things. The cohort is heterogeneous. And there's no data in this paper, obviously, on the hospital-based interventions, which could obviously affect the outcome, where they got rapidly into an operating theatre, where they went to CT. What went on in the hospital wasn't particularly wasn't reported. Simon.
Yeah, so I love these lines. I think they're fantastic. If you're trained up on them, they're incredibly quick to put in, using a landmark technique through the subclavians. I grew up before we used ultrasound for central lines. So most of the first 50 lines I ever put in, probably if not more, were just on blind technique. And we can teach this, and we've got the models and the mannequins to do it. It's quick, it's easy, it's pretty safe. Having said that, I have put at least one very large line into somebody's subclavian artery who wasn't exsanguinating. This is on the intensive care unit. And you really don't want to pull that out without a friend being around, because it's a big hole in a big vessel, and that's not fun. And then the lines here are quite big, so it's a 14 French outside diameter, isn't it? 9 French. We use a different one. We use a prelude line, which is smaller, and we put an 8 French or a 5 French in. For the 5 French, you can just, if you put it in artery, even if it's subclavian, you can probably remove it without having IR or vascular surgery around. But as a concept of getting these in, absolutely, very, very straightforward with a bit of training. The question is, should this be something, at what level should we be asking people to do this?
It's a good question. I think part-task like in vivo, doing it in hospital with real patients, but also training that muscle memory and the various steps is so important. So I think it does lend itself to part-task training, but also the patient population. And if you look back to the previous, we talked about the thoracotomy or the traumatic cardiac arrest group. If you're putting the trauma line in someone who's exsanguinating in an asystole, it's probably not a good indication. I have no evidence to support this, but I'm pretty some of the trauma lines that we've put in people who are agonal or PEA, because that line is very close to the right atrium and you give product right in towards the heart, I think that stretch of a young, particularly young, healthy heart gets the heart going again, because you fill it and then it just wants to start beating again. So I think that's a consideration in comparison to a line that's down in the femoral and has a bit longer distance to go.
And there's no doubt, I mean, the flow rates that you can achieve through this as compared to IO, which is often what people have done, can't get the IV, they put the IO in. You might get an IO that runs well. Most of them for blood products, they don't run well. You've got somebody syringing in with a 20 or a 50 ml syringe, whereas these things you can get a proper bolus of fluid through. So absolutely 100% agree.
Another question I have for you then is, in your HEM service, and we're considering this in ours, should a trauma line insertion be a clinical KPI in a shocked trauma patient?
It isn't. We've just recently audited our use of these, so it's something we're moving towards. I don't know. I mean, if you can get peripheral access and it's quick or it's already there, then I wouldn't go putting one of these in. But in the patient who looks as if they're going to be very, very difficult, then it's going to be, I'm doing this early and ideally before they've exsanguinated and died. Yeah. So again, it's not a procedure of last resort. No. It's a procedure that we should be capable of doing in patients who are not necessarily fully awake, but are still breathing and talking and got a pulse.
The other...
No.
Oh, no, not going.
No. Now, we practiced what would happen if they started talking for too long. And I didn't think I was going to have to use this, but I am. Chaps, it's great, but seriously, we're 5 in. There's so many left. All right?
Yep. I think we also agreed you're in charge of timing, but carry on.
Oh, because you've seen how easy it is to stop them talking. Now, we have come to the end of our pre-hospital section of this, and we've done 5 papers. Now, Luca is in the room somewhere as well. Luca was second author on that paper, you'll notice. So I think all of these papers probably have somebody in the room who had something to do with it. Now, I just want you to have a little chance for a mental break, because that's been a pretty hardcore moment. We're going to move on to emergency medicine in a minute. But I want you to have a think about which of these papers you think will have the biggest effect on your life going forward. There isn't the best critique. It isn't the most handsome author. It isn't any of those things. I just want you to give it a thought. Maybe, now, I'm a crashing introvert. You may not believe it, but I am. So if somebody were to say this to me, I would tell them to go away. Have a chat to the person next to you. Introduce yourself to them. Say, oh, hello, I'm really interested in hemorrhagic shock. How about you? It may work, I don't know. But I want you to have a chat, commit to it, have a little squeeze of those legs, get the blood flow going, and we'll be back in a bit, in like 1 minute's time to continue with emergency medicine. Have a think. Which is your favourite? Cast your vote now. Okay, lads.
Everybody's talking at me. I don't hear words they're saying, only the echoes of my mind. People stopping still. I can't see their faces, only the shadows of their eyes. I'm going where the sun keeps shining through the pouring rain, going where the weather suits my clothes, banking off of the northeast winds, sailing on summer breeze, and skipping over the ocean.
Okay, that's long enough to meet people. Okay, let's take our seats again, if you don't mind. This is literally the conference equivalent of swiping left or right, okay? So... Okay.
Oh, interesting.
I think I'm doing etomidate.
Don't make me shout at you like I'm a school teacher.
Yeah, South African.
Everybody, get control, Iain. Control the room. Right, good, you're back. You're coming back to me, I can sense it. I shouldn't have told you to talk to people and make friends. That was a mistake, I understand that now. Okay, good. So, our winner, if we were to have winners in this, if this were to be a competition, which obviously it's not, but you're like the most competitive people I've ever met. Post-intubation hypertension and severe brain injury is our winner for the emergency medicine section. Right, let's move on. For the pre-hospital section, let's move on to emergency medicine. And same sort of deal. Okay. So, it's 2:30 in your emergency department in the morning, because we all signed up for a specialty where we still work night shifts, and we look wistfully at the ophthalmologists as they drive home at 5. Security bursts through the doors with a young man on a stretcher, stabbed in the chest, arriving by car. He's peri-arrest with an unrecordable blood pressure, agonal respirations, but you feel the faintest central pulse as you wheel him into resus. Should you be doing an ED thoracotomy in this? Is this a meaningful life-saving intervention, or is this just a futile, high-risk procedure? Who's doing this one?
I am. Right.
Brian.
Okay. Emergency centre thoracotomy for penetrating trauma. Insights from 2 South African district-level emergency centres. So keep that in your mind, district level. So often a lot of the evidence is reported from tertiary trauma centres, particularly from South Africa. And this is from 2 district hospitals in the Mitchell Plains area of the Cape Flats in South Africa, which serves about 950,000 population, usually low middle income. And this is a retrospective review from these 2 EDs. By the way, some of it was done district level from 2017 to 21. One is a standalone ED, so it's on its own. There's no in-hospital theatre, there's no blood, so just bear that in mind. And that's the scenario that these doctors and nurses work in. And they looked at the thoracotomies done in these 2 hospitals and looked at survival to discharge. So for 4 years, they got 67 patients, 50 stabs, 17 gunshot, 80% came in with signs of life. 2/3 came in with their own transport, and they're usually males in their 20s. So they had 24% survival to discharge, 32% for stab wounds, 0 for gunshot wounds. Now, these procedures are being carried out by emergency resident level or junior doctor level with no formal training in emergency thoracotomy. And they got this kind of survival rate. So, stunning. Okay, so if you look at the timings, they did produce some timings of just about how long they spent in the emergency centre before they got transferred to the tertiary hospital. But there wasn't a lot of timings on from time of arrival to the actual decision to the thoracotomy, etc. Now, they have 3 groups. They have 45 patients with pulses who came in with palpable pulses. They have 14 with pulseless with signs of life. And then they had 5 who were pulseless without signs of life. And then if you look at survival to discharge, that's how they ended up. So 29% of the people who come in with a palpable pulse discharged alive. 2 of the pulseless with signs of life of the 14, so 14%. And if you had a thoracotomy and pulseless without signs of life, your discharge from hospital was 0. 46% survived to transfer. No patients died during intra-arrest transfer. Tertiary hospital, I think, was about 20 kilometres away, and 24-hour survival is 31%, but survival to discharge is 24%. So, what we know is cardiac tamponade in trauma is treatable. What I'd like to hear a bit more about is the triggers or the decision to do the thoracotomy in the ED, particularly in a centre that has no surgical support, quite junior doctors. Most of these occurred after hours when seniors weren't around. And in fact, I think it was only about 9% occurred when a senior was around. What are the communication pathways to the receiving hospital? How is that decision making made? What's the process? What are how's the setup? And then role allocations, and then what happens to the ED when this is going on. And then I think an interesting comment or question I would have is around the psychological safety of obviously doing, thoracotomy on a young person.
Great. And we have somebody who can help us answer some of those questions. So we've seen somebody from Australia, somebody from America. Now we're going to somebody from South Africa. This is Kat Evans. She is one of the authors on that paper, works in Mitchell Plains Emergency Department. And actually, Kat, don't worry, you don't have to answer all Brian's questions there, because I want to ask you something different.
My goodness, because there was a lot.
You're in a centre that does thoracotomies often. You're either supervising them or doing them. Many of us may see this once in a career, once every couple of years. Having done this so much, what would be your one piece of advice to someone like me to mentally model how I can prepare myself for doing this procedure?
I think I think sort of keeping calm and knowing that you can get these kind of outcomes with incredibly like low resources and low things, because you come to these conferences and you get this like super high tech long discussions about diastolic blood pressure and all sorts of echo findings, all sorts of very fancy things, and it can be just a bit overwhelming, and it sort of feels like, okay, we are not important, we don't sort of know enough, we aren't good enough, like we don't know all the academics speak. And I mean, the standalone emergency department, I think in particular for me was like the one we can learn from, because I'm one of the seniors that's not around when the things are happening. But it's just to know that you actually just can do it, and it doesn't need to be so complicated. Like sometimes it's just easier just to keep it simple. And you can have okay outcomes with sort of 2 junior doctors below registrar level. Below registrar level. No registrars at that hospital. And so just keep it simple and just keep calm, and don't overcomplicate things with too much academics. If you are not working in a heavy academic sort of tertiary environment, just keep it appropriate.
Perfect. Did you take the take-home message was keep it simple and don't overcomplicate it with academic stuff? I'm just saying. Oh, thank you. Now I'll get killed afterwards, but thank you. Now, the next paper we're going to do is one that gets medical podcasters salivating at the lips. You'll have seen the RSI trial. We're going to talk a bit about that. But I want you to picture a clinical scene. So your resus room is full. You've got a septic 68-year-old man, it's me in 18 years, with multilobar pneumonia, and they're getting tired, and you think you need to ventilate them and intubate them. You've got noradrenaline running, arterial lines kind of reading, and you look at your drug trolley and you've got a choice. Ketamine, etomidate, propofol. You've used all of them, you're comfortable with different ones, but which one would you choose? Okay, this is excellent news. So we're going to move on now to talk about which maybe the latest literature would tell us we should be using. Ketamine or etomidate for tracheal intubation. Simon.
Yeah, okay, so this trial is included because it created a big buzz in social media land, and people saying that ketamine is dead, which kind of tells you what the outcome of the trial might be, and we should never be using it again. I'm glad to see that you either didn't believe that, or you're not on social media, either which I think is great. I'm just not engaging with Twitter anywhere near as much as I used to. But this is an RSI looking at critically unwell patients in the emergency department ICU settings, and looking at choice of induction agent. There's been lots of talk about this. I was glad to see that there weren't that many people going for propofol, maybe in very selected cases. But in the shocked patient, we've generally been using ketamine. However, I started off when I did anesthetics that the only drugs I was allowed to use for an RSI were thiopentone and sucks. And anything else was not on RSI, and you're a big girl's blouse. Then etomidate came in, and that was like, oh my God, this is amazing. So you could use that with sucks. And then things have changed. And then we used ketamine for a while, and everybody said you kill everybody with a brain trauma, and then that went away. And now we use ketamine pretty much for everything. So pre-hospitally, we carry ketamine, and we do carry thiopentone for status epilepticus. It's probably the ones that we use it for very, very infrequently. But this is an RCT. It's a 14-center US RCT. And what they did is they compared induction doses in a sick group of patients. So these are patients in the emergency department who need, or ICU need to be put in sleep. So they're not routine cases at all. Drug doses, important, we'll come back to this. They either used 1 to 2 milligrams of ketamine, or they used 0.2 to 0.3 of etomidate. These are reasonably standard doses in the textbooks. In reality, these are probably quite high doses for the sort of patients which I see. So a patient who's pretty cardiovascularly stable, we tend to do a 1-1-1 now for ketamine, fentanyl, and rocuronium as an induction process. That's our standard. If they're still awake, we might give them more ketamine. But these are quite big doses, and often in the very sick patients, in the shocked patients, the hypertensive patients, I'll be dropping that down a lot to even as little as 10 or 20 milligrams of ketamine at induction for the very, very poorly systolic of 60 type patients that are going off to sleep, and that's all they need. So the doses are quite big, but it is a comparison. They're given equivalent doses for both, so that's fair, I guess. Importantly, for us, certainly in my practice, these are the exclusions. And the big one at the top there is the issue that I have with operationalizing this in practice, is they took out the trauma patients. And in fact, those are the patients in whom, I've used ketamine for a long period of time, and the ones where cardiovascular instability is really important, as we've seen from Brian's presentation of the hypertension trial, but also a degree, I think, of predictability. Because the other group of patients who they did include in this study were the ones who are more complicated. The patients who are going to ICU with sepsis, with lung sepsis, and there's all sorts of physiological stuff going on with that group of patients, which is slightly different to the pathophysiology that we see in our trauma patients. So this is what they were dealing with. So this is a different group of patients. This is the other side of the ICU when I go upstairs in my hospital away from the trauma stuff. So what were they interested in? Their primary outcome, this is really important, their primary outcome, which is what the trial was designed around, what it was powered to do, the analysis was done, was for death at 28 days. They also looked at cardiovascular instability. And the way that they did that is they had somebody basically watch what happened to that patient for the 2 minutes after induction and decided whether there was a period of cardiac instability. So did they need a new dose of vasopressor? Because some of these patients were already on a vasopressor. Did they get a systolic blood pressure below 65, not SBO, don't know what that is, below 65 millimeters of mercury, or did they suffer a cardiac arrest? They actually added cardiac arrest, and they also later added in VT and VF dysrhythmias. 2-minute period, which is quite short, I think. What did they find? And this is the most important thing. There is no difference in their primary outcome. Now that is what the trial found. The social media world went mental about the secondary outcomes because what they said is, oh my God, etomidate's so much more cardiovascularly stable than ketamine. Is it? So if we do look, so it's pretty much the same across everything. So ketamine is not dead. So the average BP between the two groups, so the mean BPs, if you got ketamine, it was 112. If you got etomidate, it was 118. So overall, it didn't make a big difference. But what about the patients who did drop their BP to significant levels? There was a slightly increased rate if you got ketamine versus etomidate. About 1 in 20 patients will drop below 80. But again, as we talked about before with the hypertension trial, hypotension think of it as a dose. It's how low do you go and how long are you at that level for. If somebody just has one single reading below a level, that would trigger you as being a negative outcome in this trial for the secondary outcome for the trial. But is that as important? The other thing is one of the reasons why etomidate fell out of favour is because of the concerns around adrenal suppression. That was largely due to people being on etomidate infusions while in ICU. It definitely does do that. Then there were other trials that suggested that a single dose probably didn't make a difference. But if you're comparing two drugs, one of which is ketamine, another's etomidate, and you're not following your patients up for a sufficient period of time to see if they have the complication of the etomidate, which everybody was worried about for 30 years, I'm not entirely sure that's a fair comparison between the two drugs. Because by 28 days, there's no difference. And that is the key message between these. So, in my opinion, they don't really cause, there's not a big difference between these two drugs in terms of patient-related outcomes, what matters to patients in this study. They both can cause hypotension. So I suppose that is a learning point, that ketamine isn't incredibly cardiac stable. There are patients who will become hypotensive with ketamine and maybe some of the other drugs that you gave. Big doses used in the study, I think we would probably have used less. I think the average dose of ketamine across all the patients was 1.4 milligrams per kilogram, which is quite a big dose in my practice for this group. So, I don't care, use what you want.
Great. And that's fine with me.
Okay, you're happy with that?
You should. So we'll move through that. I was disappointed you didn't use the phrase paradigm shift, because I've got that on my TBS bingo card. But that's okay. Let's go to another paper. And this is another, oh my word, type of situation, isn't it? A visibly pregnant woman collapses in your triage area. She's about 28 weeks by dates. She's got PEA, and despite high-quality CPR, you're not really getting away. The clock's ticking, and then somebody starts murmuring about, but 4 minutes, 4 minutes. What about 4 minutes? You've got a scalpel, a small team, but no time to have a prolonged, detailed discussion. Should you be doing a resuscitative hysterotomy on this lady? Simon.
Yeah, so I like that. This is another interesting paper. And actually, you know, when Brian and I were sort of selecting the papers, we wanted stuff which wasn't necessarily the best, highest quality paper in the world. We wanted is stuff for this audience that they're going to think about and mull over and make their own decisions. So this is another paper which I think is not a paradigm shift, but it's good on you, Billy. I said it now, you're fine. But it is really interesting. Because it does question what is in a lot of the books. So this is looking at the maternal and the child outcomes from resuscitative hysterotomy. And it's basically a review article led by Caroline Leach, who's a good friend of ours, superb clinician and fantastic person, based in the Midlands of the UK. A bunch of friends put together. And what they did is they looked for all the evidence for what actually happens when you do this. So let's just revisit the current thinking. So the current thinking you'll find in the textbooks, you'll find it on St Emlyn's, because we've written it before, Life in the Fast Lane, RC, the Royal College of Obstetricians and Gynecologists, the East Guidelines. Generally speaking, it's probably still written in print that this should be done within 4 to 5 minutes of arrest, after 24 weeks of gestation, so if you can feel a nice big uterus, just go for it. And you're doing it to save the mother. The fetus is largely irrelevant. You're doing it to change the cardiovascular dynamics to save the mother. That is the received wisdom. It's what's written down. It's what I've written down. But the thing is, where does that come from? Is it data or is it just opinion? So what they did is they went back and they looked at all the case studies, all the case series, and any other trials that were on this topic and actually looked at what happened. So what did they find? 42 papers, 132 patients. It's not a common event. 32% of these were traumatic arrests. The rest weren't. And those timings, that 4 to 5 minutes thing, it's a real issue, isn't it? If you think about the timing it takes for a team who are capable of doing the procedure to get to the woman within time of their arrest, if you do it at 4 to 5 minutes, that pretty much excludes this as a procedure if you're going to operate around that time. Unless they arrest in front of you and you happen to be next to a HEMS team, it's not happening, or in the emergency department. So it put a lot of people off doing this sort of thing. But it isn't our curriculum, we do have to train for it. So this is the group of patients. What they find was completely different to what the textbooks say. And I like this. This is dogmalysis. It's getting rid of the dogma and saying it. So maternal survival, just 4.5%, so about 1 in 20 of the mothers survived. But the neonatal survival was 45%. That's a complete shift in what we were thinking before and what we've always taught. The other thing is about timing. So timing was much, much, much longer. So maternal, these are neurologically successful outcomes for the mother up to 29 minutes after the time of arrest, but for the neonates up to 47 minutes. And if you think about it, neonates, I don't know if you've ever been present at a birth, it's pretty tough for the kid. They get squeezed. They're designed to be hypoxic. They're designed to have their cardiovascular system squeezed and their output reduced for a long period of time. They're physiologically designed to have a cardiac arrest around about the time of birth and survive. So perhaps it's not that surprising that they can tolerate this as well. Interestingly, the maternal ones, none of the maternal mothers survived. The mothers only survived if it was due to a medical cause. So, is that really enough to change practice? I think it probably is. There are limits to this. It is retrospective. It's really prone to publication bias. So I don't necessarily report when things go wrong. I tend to report when things go right. So it's likely that this overestimates the overall success rates for these. It is small numbers, selective publication, but it can be done. You can train for it. This is where we train every year in our hospital. We get all the teams together, so we practice how we do resuscitative hysterotomy between obstetrics, anaesthesia, emergency medicine, surgery, etc. It is the best data so far, and for me, it means that the window where you can do this is much longer. It's much more successful than you think it should be, and you're doing it as much for the kid as you're doing for the adults. So, in other words, everything you were previously taught was wrong. Let's do something different.
Fabulous. If there's anybody in the room who's about to be the father of a newborn child and you're going to go to the birth, I'm the father of 4 sons. I just want to say, when you're sitting there and squeezing the hand of your beloved, don't say the phrase, yes, darling, but don't forget it's also pretty tough for the kid. Because I don't think it's necessarily going to get you the sympathy you're looking for. Now, the person I'd like to ask a bit about this is Emily Holmes. If you were here last year, you'll have heard Emily's talk about how we look after providers. She's at the back. She wanted to make you work through it. There you go.
Thank you.
Now, Emily will be talking more about her specialist subject. She's a colleague of mine, actually, at Southampton University. And Emily, the thing I'd really like to ask you is these procedures, we talked about survival and we talked about how you might do them. But what about the people doing these procedures? What do you do in the aftermath for somebody, a medical professional, who's been at a scene and you know what? The mum has died or the baby has died and then they're supposed to go to their next job. How do they look after themselves when they've been part of doing a procedure like this? Emily.
Thank you. And what an interesting paper. So in answer to your question, in a really ideal world, I'd say, here's the latest evidence. This is what you do. But what we'll be talking about earlier is that the current evidence for what you do very soon after an extreme case like this, say where the mum dies, is pretty unconvincing for staff, looking after staff, that is. So if, and one of the things in the sort of psychological evidence would be the idea is looking after people's well-being. One of the common practices has been something called psychological debriefing. But after 25 years of research, the evidence is far from convincing. It's definitively null. And in some cases, even worse. If we put our research hats on, we might say, oh, we all react differently. Maybe it's really good for some people. It's masking those. It will help some nurses not go off sick. But if you look at the data, it seems to be worse for those who are most high anxious. So actually, and I know it's hard to say this, but looking at the evidence, the best thing is what not to do. Don't pathologise. Probably don't psychologise too much in the early hours. And don't pharmacologise, which means don't take sleeping agents and other things to make people feel better. But if we move back a step, what I'd really like to say is let's look at a better agenda going forward, because it's really hard to offer nothing. So what I would do pragmatically simply is say, if everyone reacts very differently, let them react in the way they do. If someone is symptomatic, if that nurse, for example, is having flashbacks the next day, only then intervene. And if you want to know what to do, I'm going to suggest some evidence about 11 o'clock today, 11:30, what you could do to help prevent that. Because what we do know is that doing something to reduce, say, flashbacks, that's haunting memories of events, is a lot better than leaving someone to be off on sick leave doing nothing or just doing a therapy that doesn't work.
Brilliant, thank you. So you can hear more from that from Emily, 11 o'clock this morning. And having heard her talk last year, it will change your minds. It will be worth going to. If you are interested in this topic, a little plug again. Our latest St. Emmeline's podcast is an interview with Caroline Leach about this paper, where she goes into more detail about all of this stuff. And it's worth a listen. OK, I think this might be our final paper for the emergency medicine section. It might not be. You're at a major trauma call, and a 50-year-old motorcyclist, why do men do that, arrives with hypotension, a pelvic blinder, and obvious ongoing hemorrhage. You've done your major hemorrhage protocol, and you've got some products on the way. But you're just wondering about, in those first 24 hours as that patient goes to intensive care, what should you be doing? Choosing a concentrate-based resuscitation or FFP? And how does that change what will happen for the patient? Brian, this is yours.
Cool. All right, so factors in the initial resuscitation of patients with severe trauma, the first two randomized clinical trial. And, you know, I think it's a good thing that we're getting a lot of now randomized controlled trials in bleeding. There wasn't many, 20, 30 years ago, but now there's a renewed interest. People are trying to study it, but there are challenges with that, and we'll talk about a little bit about that. So this was done in Canada. It was done at 6 major trauma centres, involving major hemorrhage protocol activation, and patients either got, it's done from April 21 to Feb 23, and it's a 1-to-1 randomization. This is the intervention, so they either got Fibrinogen concentrate 4 grams, plus PCCs 2,000 units, or FFP by 4. Now, they all got 4 RBCs in the first and second packs. They all got that. They all got platelets in the second pack. And they all got 2 grams of TXA if it was under 2 hours of injury. And the treatment period spanned from randomization to 24 hours or after the second massive hemorrhage protocol pack, whichever was first. And they powered a mean difference of 5 units. And it's one of the challenges with these trials. I've been involved in these trials. You come up with a pre-specified power, and then you don't necessarily reach that. There was a lot of exclusions. Okay, so they excluded patients who got greater than 2 packed red cells pre-hospital or prior to the MTP activation, or they're more than 3 hours from injury, which sounds like a long period of time, but in the Canadian and Australian environment, that actually does happen. Penetrating TBI and GCSS3 were excluded. If they're on anticoagulants, they were out. If they were pregnant, they were out. We could spend a whole session talking about the ethics of excluding pregnant women from trauma trials, but we don't have the time. Bleeding disorder, refusal of blood transfusion. They're followed up to 28 days. The primary was blood products within 24 hours, and the secondary were mean products within 24 hours, and excluding FFP in the first 2 packs. They had other secondary outcomes such as safety, such as VTE, ventilator-free days, duration of ICU, multi-organ failure, the usual kind of stuff. Okay, so they enrolled 217 patients, 69% were blunt, and they had a median ISS of 29. So you can see this patient population is a similar population we talk about at this conference. Okay, and this is what they found. So the group that got the FC and the PCC, they got 20 units, and the ones that got the FFP got 23 units. Non-significant, no difference. What's interesting in terms of just some of the other elements of this study was that the median systolic in the FC-PCC group was 108. Quite shocked patients in terms of their ISS, or quite severely injured. And it was 127 in the control. 73% of all these patients needed a hemorrhage control procedure, either IR or open surgery. So, quite a resource utilization. And the median time from arrival to the massive transfusion activation was 49 minutes. Now, I think we all like to think we're faster at activating massive hemorrhage and recognizing trauma patients who are bleeding. But that seems like quite a long time to me to recognize and to start the massive transfusion protocol. The median time from arrival was 40, and then the FC-PCC actually took longer to get into them than the plasma, which is counterintuitive because the PCC and FC sits on a shelf. So I was quite surprised by that. There was no difference in secondary or safety outcomes. And the trial was actually stopped early because interim analysis said the power is less than 25%. So one of the things I thought about this trial is, are we comparing apples with apples? Are you comparing the right comparison in terms of FFP versus fibrinogen concentrate and PCC? And you could argue you're not. There's a lot of work going on trauma-induced coagulopathy, but also trauma-induced endotheliopathy. And we know that FFP seems to help, although we've no high-class evidence for it, endotheliopathy. So I don't think we're comparing the same things here with this trial. And I think one of the keys to the future of trauma trials and bleeding are more likely to be adaptive platform trials. And certainly we're designing one of those in Australia at the moment, where you can hone down and optimize patient selection for the pathology. So the pathology you're generally trying to treat in these trials is trauma-induced coagulopathy. But we don't really know if they have it, and we're just giving them the treatment as if they do have it. And I think a lot of that's going to be data-driven, and machine learning will help in those patient selections, I think, to better predict someone who has it, or either measure that they do have it and then enroll them. We're running the FEISTI-2 trial study at the moment in Sydney, and you actually have to have proven coagulopathy to go into this study.
Fabulous.
Okay. I just might quickly go to Simon, because we've had the PROAG and we've had cryostat,
PROCOAG,
iTactic.
Yeah, and all those studies. So within this area, a lot of these studies come out with negative results, no big difference. So PROCOAG didn't, cryostat 2 didn't really. But then an iTactic was where they did bespoke replacement of blood products using Rotem or TEG. All of these trials have come out with no major effect across the piece, but all of them have come out with subgroups which really look as if they might be quite interesting for further analysis. So things like in iTactic, then there was a signal about it being potentially much better for the brain injured patients. Things like PAMPA trial, which was FFP versus red blood cells, and a slightly different thing. But again, it was the patients with the brain injury who showed benefit. So we clearly don't understand this, and it may well be this issue around endothelial injury. So yeah, there's a lot more work to be done here. And don't be too put off by the negative trials. It's just that we don't understand it when we apply broad brush, full approach to just everybody without thinking about it a little bit harder.
So more precision. Okay.
Fabulous. And now, for those of you who are caffeine dependent, which I won't do a poll on, but I'm going to say it's 85% of you, we are almost there. We're going to do our last paper. This is our last emergency medicine paper. And I want you to picture the one final scene. So you work in a regional system that's built an ED-based ECPR pathway. You've got a candidate today who is, let's say, 50 years old, with witness VF and good bystander CPR and an ongoing arrest during transport. EMS call ahead to tell you that this might be a candidate who's suitable for ECPR. But the real question is this a good use of resources? And is this somewhere we should be going in the future? This is our last paper, and I think this is with Brian.
Cool. All right. So this is implementation of a regional emergency physician initiated ECMO CPR system. This is from Zach Shiner in San Diego. He started in his place, and then they have trained other hospitals in the San Diego area. So it's a county-based EMS to ECMO response. So this was a prospective observational cohort, county-led ECPR systems. So the EMS systems within San Diego will look out for ECMO-eligible patients, and they'll do what's called an ECMO alert and transport the patient to the nearest ECMO CPR hospital. So once they get to the hospital, they'll validate the out-of-hospital criteria, and then they'll proceed. Now, the outcomes, they wanted to look at the primary outcome, which was EMS dispatch to ECMO flow, which is reasonable, and secondary is to look at neurologically intact survival. So they got 89 alerts during the time period. Now, of those 89 alerts, non-ECMO considered, 21 or 25% of them survived neurologically intact. Now, these are refractory prolonged cardiac arrest. And you saw in our own evidence trial in Sydney, that population had about a 16% survival. So 25% survival in patients who are arrested for anything from 45 to 60 minutes is a really good outcome. In terms of the arrest to ECMO flow patients, that was 61 minutes, and 7 of the 22 ECMO patients survived neurologically intact. Now, in terms of their group, they had actually 31 physicians cannulate 22 patients. 2 of the newer expansion hospitals did 8 of those cases, 3 of whom survived neurologically intact. So the newer sites that came on with this very different training program, very short curtailed training program, did well. There was failure in 2 patients. 1 patient ended up on VV ECMO, and 1 had an inability to flow onto ECMO. And coming back to Simon's point earlier on around cardiac arrest and the criteria, it is really a funnel of a lot of arrests to get down to that small group of patients who are ECMO eligible. So we do know they're a small number. They're not that common. There seems to be a system level improvement, though, that comes with this, and certainly from our own observation with the PRECARE trial in Sydney, because there's so much engagement in cardiac arrest and interest in cardiac arrest, I do think there is a Hawthorne effect around the rest of the system in places that are developing advanced resuscitation techniques. Anything to add, Simon? No.
Brilliant.
Cool.
Now, I was hoping that we'd have Anne Weaver here to chat to, but she's not arrived yet. But she's such a hero of mine, I left the picture in. So that's what Anne looks like. She's phenomenal. She'll be here later in the week. And that brings us to the end of our 5 papers talking about emergency medicine. And again, I just want you to have a little think about which of these papers is going to make a difference to you. Not the level of the critical appraisal, but the topic itself. This is your final chance to vote. I want you to have a go, see which one it is that you think will be the one that will make a change and make a difference for you. So there we go. Caroline, I'm sure, will be delighted, and even more reason for you to go and have a listen to St Emlyn's. That has brought us to the end of our session. Thank you so much for having us. We've had a great time. If you are interested in something I've done, then have a look at that. If you're in something that me and him do, have a look at that. And if you want to hear about a general Australian hero, have a read of that. I hope you have the most fantastic time this week. Simon and Brian, thank you.